So we are here with Professor Dominique Valla. He is a very expert on portal hypertension and portal thrombosis, and I would like to propose to him a clinical case so we can discuss and learn with him. The clinical case is a patient who performed a bariatric surgery 3 years ago. During his follow-up, he performed endoscopy and was found 3 varices, large varices. So he went on an investigation and he found a portal vein thrombosis. He made an investigation for liver diseases. No liver disease was found. He performed an elastography, and the elastography was 9.5 kilopascals, so probably not a cirrhosis. This patient performed an investigation for coagulation diseases. Nothing was found. So we had a patient with large varices and a portal vein thrombosis, probably associated to the bariatric surgery 3 years ago. So I'd like to ask 3 questions. The first one is, should we go directly to anticoagulation or should we do anything before? Is it necessary to bend the varices before the anticoagulation? And so that's it.
Okay, great. We'll address first the second question, which is the prevention of bleeding from varices. I think this should be the first thing, because we cannot discuss anticoagulation without this step having been reached. I think I would give both beta blockers and bond ligation, because in patients with cirrhosis, it's now considered to be the preferred way to prevent first bleeding, prophylaxis. It's very new. Otherwise, just beta blockers would have been enough. The issue is when to begin anticoagulation, if we decide for anticoagulation. Is it when the varices have been eradicated or so? No. We just have to initiate the treatment for prophylaxis, go the usual speed without delay, and then we can initiate anticoagulation early. This will prevent an aggravation of thrombosis, because we must not forget that preventing thrombosis is more important than preventing bleeding for prognosis. So first, prevent the recurrent bleeding. Second, anticoagulation. Yes. As soon as a thrombus in the portal vein is found, I think that anticoagulation is needed whether or not there is an underlying liver disease. It's now clear that there is an overall benefit to this, and that even in patients with portal hypertension, anticoagulation does not increase the risk of bleeding from portal hypertension. On the contrary, there is evidence that it decreases the risk, maybe because it is treating the block and decreasing portal pressure, maybe. So the anticoagulation, certainly. Whether we should add something to anticoagulation, like thrombolysis, is to me a more difficult question. There are several things that must be taken into account when we think about this issue. The first one is that just with anticoagulation, we know that we are able to recanalize 60% of the patients with portal vein thrombosis, complete portal vein thrombosis, even if there is an extension to the superior mesenteric vein. So just with anticoagulation, we can achieve that, except that we will not achieve it in 2 days. It will take several weeks. But during this time, on anticoagulation, there will be no progression. So we are safe. The patient has no evidence of ischemic intestinal disease or things like that. So we are safe. We can initiate anticoagulation. Prevention of variceal bleeding is underway. We are safe. We need to do better. Why should we do better? Well, we know that on anticoagulation there will be no severe complication like gut ischemia and so on. Maybe because we want to prevent the development of a cavernoma. Because the cavernoma will mean permanent portal hypertension. Here I have a comment that when there is just portal hypertension without liver dysfunction, without liver disease, the prognosis is very good. Just portal hypertension, we know how to manage. Nobody never dies from portal hypertension alone. So whether we should go further and recanalize is dependent on the risk of the procedure for thrombolysis. And from the published data, it is not so good. I know that the individual experience of the interventional radiologists and teams are now very, very favorable to this without serious side effects and so on. But this has to be written, this has to be studied, you know. The data are there, but they have not been exploited, because if you look at the existing literature, there is no benefit to interventional radiology for thrombolysis in patients with recent portal vein thrombosis. So I think we have to take this in mind. So it's not no for thrombolysis, but what for? To have a free portal vein. Is it better than a cavernoma? We can say that, but there is no evidence, but it is logical. Okay. So yes, my conclusion would be yes, consider thrombolysis, but be sure, or I'm sure with the radiologist, that there is no risk with the procedure.
Perfect. One last question.
Oh, yes.
Which medication would you choose for anticoagulation?
First of all, the choice will not be based on strong evidence, but I think there is a good agreement that apixaban, DOAC, is currently the drug with the best profile. In this case, it's a patient who has an underlying liver disease. We don't know exactly which one, but the stiffness is increased, so there is something in the liver, being a MASH or something. We don't know, but anyway, there is something, but still there is no marked liver dysfunction. So the DOACs can be used.
Thank you very much. I'm sure that everybody will learn a lot with your experience.
Hope to have been clear.
Thank you very much.
Thank you.